Welcome to the theoretical lecture on the spinal cord and the motor pathways. First we have the spinal cord, which is located in the vertebral canal, extending between the pyramidal decussation, conus medullaris, with the filum terminale, and it connects with the medulla oblongata of the brainstem, the superior border of the atlas, below the foramen magnum. Its conical end is known as the conus medullaris, the level of the inferior border of the first lumbar vertebra, and also between the superior border of the second lumbar vertebra. It has 31 pairs of spinal nerves. Of course, its dorsoventral roots of the lower lumbar, sacral, and cochlear nerves are called cauda equina. It has two enlargements, cervical lumbar or lumbosacral. There is a structure known as the funiculus, made of external white matter, dividing into anterior funiculus between the anterior median fissure and the anterior lateral sulcus, the anterior root entry zone, lateral funiculus between anterior lateral sulcus, posterior lateral sulcus, posterior funiculus between posterior lateral sulcus, posterior root entry zone, and the posterior median sulcus. It contains in the cervical part the gracile funiculus, which is more medially, while the cuneate vesiculus is more laterally. The gracile vesiculus and cuneate vesiculus is the posterior intermediate sulcus. Columns are organized into internal part, gray matter, divided into anterior, lateral, and posterior columns, with either nuclei and spinal laminae. In the cross section, of course, we see this butterfly-shaped structure, the H-shaped area made out of the gray matter, with an anterior horn of the motor overflow, which contains motor neurons, spinal laminae 7 to 9, anterior medial and posterior medial nuclei, supply muscles of trunk, anterior lateral, posterior lateral, radial posterior lateral nuclei, supply muscles of limbs, central nucleus, cervical part, the nucleus of phrenic nerve, and there's also nucleus of the accessory nerve. Posterior horn, sensory processing, including spinal laminae 1 to 6, are going to the head and neck, base of posterior horn, between apex and external surface, its marginal zona, and gelatinous substance, important for the induction of pain stimuli. The posterior horn contains nucleus proprius, and these axons form afferent pathways, somatosensory. And there's also thoracic nucleus forming dorsal spinocerebellar tract. Intermediate gray matter consisting of central and lateral intermediate gray substance. Lateral gray substance developed in the thoracic part and forms lateral horn with the spinal laminae 7. There's the intermedial lateral nucleus, sympathetic C8, L2, L3. The medial nucleus, parasympathetic S2, S4. There's a central canal, it's part of the ventricular system, present spinal cord surrounded by gray matter, anterior and posterior gray commissure, and also some white commissure. Conus medullaris contains terminal ventricles with roots of spinal nerves anteriorly, anterior lateral sulcus, posterior lateral sulcus. Then there are some spinal meninges, developed by G meninges. There's nothing too groundbreaking. Basically, there's also the spine duramater, separated from vertebral periosteum by the extradural epidural space. Then the arachnoid mater lining this dura mater with trabecula linking to pia mater. The articulate ligament anchors the spinal cord arachnoid to the dura mater. The pia mater covers the whole of the spinal cord, lines its anterior median fissure, subordinate space between arachnoid and pia mater surrounding spinal cord and brain. The L1, L2 are of the subordinate cistern or lumbar cistern, are a favorable place for cerebrospinal fluid puncture. There's like a blood supply, post arteries, anterior spinal artery bifurcates from the vertebral artery, goes through the ventral median fissure, and then it's opposed to a scanning cervical artery, posterior intercostal artery, lateral lumbar artery, which we call the radicular arteries, which are also branches of the vertebral artery. From the anterior spinal artery also comes the sulcal artery, which supplies spinal cord segmentally. Then there's the posterior spinal artery, again also a branch of vertebral artery. So it's dorsal part, but it doesn't form one blood vessel. Only anterior spinal artery does. Receives segmental support from radicular arteries, divided into anterior to ventral spinal artery, posterior to dorsal spinal artery, accompanying the roots of the spinal nerve. The vasocoronary artery connects the segmentally anterior spinal and posterior spinal arteries. Then veins of spinal cord, similar fashion with the anterior spinal vein, anterior fissure, receiving blood from segmental veins, sulcal veins, receiving from anterior medial part of spinal cord, posterior spinal vein at posterior fissure, posterior lateral spinal veins on the posterior surface, lateral posterior spinal vein joining the posterior funiculus and posterior horns, with again a venous vasocorona connecting anterior spinal vein with the posterior lateral spinal veins and the posterior spinal vein. Now, like the basics of the pathways. Basically, there are the short intersegmental fibers lying close to the gray matter of the spinal cord. They are present in all funiculi and form anterior, posterior, and lateral proper fasciculi. There are the jerks for proper spinal cord activity, contain at least two or more neurons. Examples like the knee jerk, ankle jerk, biceps jerk, with scanning fibers in its posterior column, periphery of lateral column. Scanning is anteriorly, and the intermediate part of lateral column of spinal cord. Then there are the efferent pathways. We separate pyramidal and extrapyramidal pathways. The upper motor neurons, UMN. Within the cortex, there is the primary motor area, premotor area, and also affects the paracentral lobe. The lower motor neurons, MN, in the anterior horn of spinal cord, giving axons, anterior roots, forming spinal nerve, terminal axons at neuromuscular junction, brainstem, who passes axons to motor plates of striated muscles. Its locations being the corticospinal pathway is in the anterior horn of the spinal cord, corticonucleate pathway, general somatic efferent nuclei, the hypoglossal 12 abducens nucleus, 6 trochlea 4 oculomotor 3, special vessel, so more to the organs, the ambiguous including 9, 10, and 11. The facial one, CN7, the geminal, CN5, with its branches. Okay, pyramidal tracts. They're connected with the voluntary movements, include two neurons, upper motor neurons, divided into corticospinal and corticonuclear tracts. Lateral corticospinal tract is the lateral funiculus, cross level of pyramid accusation terminating in interneurons of anterior horn, level V2, includes fibers controlling the trunk and muscle as well as proximal joints. Anterior corticospinal tract lies in the anterior funiculus, uncrossed or maybe even crossed at segmental level, terminates in the same lamina, includes fibers controlling the trunk and muscle of the proximal joints. So really the only difference is the indefinite crossing, because the lateral corticospinal tract crosses for sure at pyramidal accusation. And there's the origin in the cerebral cortex with pyramidal cells rising from upper motor neurons. The first neuron passes corona radiata, posterior limb of internal capsule, crus cerebri, longitudinal pontine fibers, pyramidal accusation of pyramids, below the junction of the medulla, lateral corticospinal tract, pyramid anterior corticospinal tract. Its termination at the gray matter of spinal cord anterior horn, spinal lamina 7 to 9. And the corticonuclear tract or corticobulbar tract, projecting to cranial-motor nuclei in the lower brainstem. There is the GSE, which includes hypoglossal, abducent, trochlear, oculomotor. SVE, ambiguous, facial, trigeminal. The sensory related nuclei are the nucleus crasilis, cuneatus, trigeminal sensory nucleus, solitary tract nucleus. The reticular formation, cortico-reticular fiber. Then there's the bilateral fibers going to laryngeal, pharyngeal, palatal, and upper facial muscles, muscles of mastication, and extraocular muscles. Only lateral fibers going to lower facial muscle, facial palsy, muscles of tongue. Sternocleidomastoid, short SCM, and trapezius uncrossed to spinal accessory, and there's pseudopulvar palsy when there is a syndrome of the bilateral UMN lesion. When there's, or in case of an LMN syndrome, it would involve the direct damage to motor neurons that innervate muscles at the clinical examples for like this condition known as poliomyelitis, and basically it always lowers the activity. So you got something like hypotonia. Then you have upper motor neuron syndromes with damage to the scanning pathway of the motor system, which has an increased activity, so hypotonia or an increased Babinski sign. You also got other conditions potentially like atonia, lack of tone, dystonia, dyskinetic, disordered movements. Hypotonia is the greatly reduced tone, with the hypotonia is greatly increased tone. Paralysis, inability to effect voluntary movements. Paresis, incomplete or partial paralysis. Fibrillation, spontaneous concentrations of single muscle fibers. And fasciculations about a group of muscles. Extrapyramidal tracts, they assist the pyramidal system in body balance, tone of muscles, automatic movements. It cooperates with autonomic nervous system, motor sensory part of cortex, and is connected to the cerebellum with the motor cortex, posterior part of frontal gyrus, having superiorly being the center of complex trunk movements, middle the center of coordination for head and eyeball movements, inferiorly motor speech area, via the subcortical nuclei found in basal nuclei. There's the striatum, is the center of muscle tone, automatic movement, subthalamus of the forebrain, with its nucleus respectively responsible for balancing movements of limb, substantia nigra for coordination of fast involuntary movements, red nucleus, coordination of centers of extrapyramidal system, cortex cerebellum vestibular nuclei muscle of the reticular formation and vestibular nuclei to the lower motor neurons. Um, there are the tracts of extracellular system, which are multi-neuronal pathways. The striatum has afferent fibers going from cortex substantia nigra and thalamus, thin fibers to globus pallidus, substantia nigra. Globus pallidus has afferent fibers from striatum, subthalamic nucleus, efferent to thalamus, subthalamic nucleus, reticuloformation, olivary nuclei. Substantia nigra are afferent fibers from striatum, putamen frontal cortex. Afferent fibers, striatum, thalamus. Red nucleus afferent from contralateral dentate. Ipsilateral contralatus buccalicus, as well as globus pallidus, and ipsilaterally affecting frontal cortex. Efferent cortex has the rubrospinal, rubroreticular, and rubro-olivary tracts. The most important efferent tract, however, is the extrapyramidal system. When the extrapyramidal system is the central tegmental tract. It passes to the olivary nucleus with rubro-olivary, rubro-reticulary tract, and pallido-olivary tract. They pass to the cerebral cortex via olivary cerebellar tract. Then pass spinal cords, influence motor activity. It's the scanning pathways being rubro-reticulospinal and vestibulospinal tracts. Here's some more examples. Rubrospinal tract originates midbrain, red nucleus, crosses fibrous ventral part of tegmental decussation, and goes anteriorly to lateral corticospinal tract. Tectospinal tract originates superior collicus and forms the medial longitudinal fasciculus through the medulla. Its fibers cross raphe region and ending in the anterior medial part of anterior funiculus. Vestibulospinal tract originates in lateral vestibular nuclei, then runs in the anterior part of lateral funiculus. Reticulospinal tract origins in pons medulla, go ipsilaterally in anterior funiculus. There's the autonomic system with diffuse projections of tegmental nuclei containing aminergic transmitters, the raphe nucleus, serotonin, locus coeruleus, norepinephrine, visceral nuclei in the medulla project to sympathetic parasympathetic nuclei of the spinal cord. Then there is the serotonic pathways controlled by the raphe nuclei, its location being midline continuous column. It follows the substantia gelatinosa, which we know is the central pain control system. Then some of its fibers would terminate in the intermedial lateral cell column, and the scanning fibers be involved in sleep wake cycle and affective behavior like depression. And there might be vasoconstriction of the cerebral blood vessels. Then there's noradrenergic path in locus coeruleus, pontomedullary reticular formation. Its role in sleep-wake cycle is essential, increasing attention and vigilance. The dopaminergic path from substantia nigra, pars compacta, ventral tegmental area, and midbrain, with output to striatum, caudate putamen, nigrostriatal path, and output to septum, amygdala, frontal lobe. There on the right, on the schematic view, we see the connections between the pyramidal and extrapyramidal pathways. Okay, scanning pathways or tracts. The corticospinal tract carries information for voluntary, discrete, and skilled movement. Tectospinal tract mediates reflexive head and neck movements in response to visual and vestibular stimuli. Rubrospinal tract control of tone muscle and distal part flexor groups. Vestibulospinal. Okay, so rubrospinal is flexor groups. Vestibulospinal is extensor groups. With effect on anti-gravity extensor muscles. Then there's the reticulospinal tract for the axial muscles of neck, trunk, and posture. We can count on several lesions like paresis, with the loss of muscle tone and gradual increase of muscle tone in anti-gravity muscles, hyperactive deep tendon myoctic reflexes, also loss of superficial abdominal cremaster reflexes, appearance of an extensor response, the infamous Babinski sign. Then motor commands generated centrally could alter transmission of spinal reflexes, damage to CNS, producing alterations in the reflex response muscle tone. For example, interruption of scanning pathways produces spasticity. Transaction of spinal cord leads to a period of spinal shock followed by hyperreflexia. The injury to motor roots affects muscles like increased weakness, wasting of fasciculation, loss of tendon reflexes. And there's a sensory symptom, unilateral lesion, result in anterior signs like the loss of pain and temperature sensation on the opposite side, unilateral, and loss of discriminative touch, vibration sense, and position ipsilateral, below the affected segment, the Brown-Séquard syndrome. There's also polyneuropathy affecting multiple peripheral nerves, but predominantly cutaneous sensation loss in hands and feet, attributed to impaired axonal transport. Basal ganglia is also extrapyramidal, organizes input from eyes, motor cortex, cerebellum, producing something we call skill or grace. Now lastly, there are the reflex arches. It's about the lower motor neurons activity via the monosynaptic pathways. There are the deep tendon reflexes, the knee jerk being a monosynaptic reflex. There's a patellar tendon at the knee, like it's structured behind the knee, which has a stretch receptor to the anterior horn cell. Basically, a way to remember what segmental level induces which reflex, as we see on the table. There was like kind of song. First there was like deep tendon reflexes, it's root supply. And, basically it says that 1-2 buckle my shoe, S1-2 is the ankle jerk, then 3-4 kick the door, L3-4 knee jerk, 5-6 pick up sticks, C5-6 biceps and brachioradialis, 7-8 shut the gate, sit 7-8 is the triceps. With this rather monotone song, I would end this lecture. Hope you had fun.